Good afternoon. I'm Aaron Levo. I'm the Vice President of Communications, Public Affairs, and on interim basis, Human Resources. Pleased to be with you again today on October 20th to moderate our town hall. As I said a moment ago, the town hall is always recorded so that people can watch it after the fact if they haven't been able to be here in person, which I know is the case for so many of you that are working throughout the day today and just can't make time. But we do have a really great agenda. We have a number of presenters here today. We will have the Q&A function open so you can ask questions as we go through the presentations, and the content experts that are with us will answer them. Those answers will pile up in the answered tab. So if you go in the Q&A function at the bottom of the screen and look in the answered tab, you will see the responses to questions that have been raised. And we'll reserve our chat function for the conclusion today when we do our celebration. So Q&A for questions, chat function for celebrations, and we will have, think of that as you go throughout here, not just questions, things that you'd like to celebrate or regard upon, colleagues you'd like to shout out, teams, things that have happened that are wonderful. You can do that at the end. All right, so that's enough of the housekeeping. I will introduce our first speaker. Dr. Michael Stacey is our EVP Academic and Chief Medical Executive here today on behalf of our President and CEO, Rob, who couldn't be with us. So Michael, over to you.
Yeah, thanks very much, Aaron, and good morning and welcome everyone to today's town hall. And as Aaron has indicated, I'm happy to be here today covering for Rob McIsaac. As we begin, I'd like to acknowledge that we are privileged to provide care on lands that Indigenous people have called home for thousands of years. We do recognise and respect the presence and stewardship of all Indigenous peoples as keepers of this land. Before we move into our planned agenda, I would just like to take a moment to acknowledge the situation that's been unfolding in Iran and also around the world in recent weeks. I think you're all aware that the death of Mahsa Amini in the custody of Iranian police on September the 16th has led to widespread and often violent protests across that nation. There have been dozens of protester deaths and injuries resulting from that violence. On behalf of the Hamilton Health Sciences leadership team, I extend my regret and support to the local Iranian community as these terrible events continue to unfold, as we know that these do impact many of our local people. So if you've been affected by the situation in Iran and do require support, I encourage you to seek out our HHS Employee and Family Assistance Program and the many free resources that are within that. And together, let us sort of all maintain hope for peace in Iran and for the advancement of women's rights there and also around the globe. We have a number of important topics to cover today, so without further ado, I'll hand over first to Kelly O'Halloran to provide an update on the HHS annual United Way campaign. So over to you, Kelly.
Thank you and good morning to everybody. On behalf of Sandra Frazzari and I, as co-chairs of Hamilton Health Sciences United Way Committee, we would like to share our excitement around our kickoff, which will begin October 31st officially. We have had an early bird draw that many of you likely saw for some Tiger Cat tickets for the game tomorrow. That closes at 12 o'clock today. The mandate of the United Way, Halton and Hamilton is to bring people and resources together to bring strong, healthy, and safe communities for all, or to build, sorry. It is a collective mission to serve the needs of those in crises, tackle systemic barriers, and create an equitable future of opportunity where everyone can thrive. When you give to United Way, you are helping to sustain a network of local programs that act as a safety net so that the most vulnerable can access the supports they need. This safety net supports health promotion and prevention for vulnerable people. And by doing this, we have the ability to optimize their quality of life. And in doing this, we likely will see a reduction in hospital visits, ED visits, and admissions because people will be healthier and a lot of their care can be provided in the community. Please consider making a financial donation if you are able, either through a one-time gift or payroll deduction. We would also love to see you join our fundraising events through October 31st to the end of November. This year, we will be bringing back the best Halloween costume at the General, Juravinsky, St. Peter's, and Urgent Care. We will also be bringing back the Bowl-a-thon that will occur on November the 30th. We will have Dress Your Way days and other raffles. So stay tuned. This information will be provided on the hub, and we really would love you to participate. And again, consider that one-time donation or payroll deduction. And if you're already contributing to through the payroll deduction, if it is possible for you to increase that deduction, please consider that also so that we can help our community. This is where HHS shines. As the largest employer in the greater Hamilton region, we have the power to make a difference. And we've done this year after year. Together this year, our goal is to raise $90,000. So again, please keep an eye on the hub and watch for opportunities to participate in our fundraisers and for more information about payroll deduction. I want to welcome Kira McDermott from United Way, who will share a little more about this vital campaign. Thank you, Kira.
Thank you so much, Kelly. As Kelly said, I'm Kira from United Way, and I'm so grateful for the opportunity to speak with you today. It has been a difficult past few years, and unfortunately, we still face challenges ahead. We are anticipating even more people requiring assistance, especially due to the rising cost of essentials, which is making it difficult for our neighbors to meet their basic needs. United Way funded agencies can provide this much needed assistance for our neighbors, but they need support. Last year, 43% of United Way funded programs saw an increase for demand, and of those reporting an increase, 29% indicated a lack of resources. Finally, 49% of United Way supported programs have wait lists of individuals who need their services but are unable to access them. Next slide. Now, I know firsthand the positive impact United Way has on our community because I used to work at a United Way funded agency. I supervised girls empowerment programs where school-aged participants increase their resilience and confidence through weekly sessions. Today, I'd like to tell you about Anna, a participant who joined our Baseball for Development program. Anna joined this program and started out without a lot of confidence in herself and her abilities. She especially struggled with stepping up to bat. Now, this is pretty common because for many of our participants, it feels isolating and like everyone is watching if you make a mistake. The staff did a great job of encouraging Anna to build up her abilities through using a tee, practicing her stance and swing, and brushing off mistakes when they happen. But most importantly, the staff made sure to create a safe and nurturing environment, teaching the participants the importance of supporting their teammates through encouraging words and cheering each other on. Anna made such great progress through just 8 weeks of the program, and at the end, the girls in the program were invited to the Rogers Center for a celebration. The participants were divided up to play baseball games with other girls from across Ontario, and Jordan Romano, pitcher for the Blue Jays, was volunteering at Anna's game and actually pitching to the girls. When it was Anna's turn, it was so fantastic to see the confidence she showed stepping up to bat, and she actually hit a home run off of Romano's pitch. I know this confidence that she developed within the program translates to how she feels about herself in her everyday life too. I share this story just to highlight the fact that these programs and positive impact on the girls who participated could not have happened without the ongoing support from United Way. Next slide, please. I invite you today to consider supporting United Way to help our community survive the challenges our society is facing. So for about $10 a pay, you can provide 52 healthy meals to seniors at a day program. For about $20, you can provide counseling to enable 12 community members to live debt-free. And for about $50 a pay, which is a leadership level donation over the course of the year, you can provide weekly music classes to 143 people with developmental disabilities for 3 months. So please look for your link to donate in your email on October 28th and consider how you can show some local love to our neighbors who really need our support. Thank you so much, and have a good one.
All right, thanks very much to Kelly and also to our guest Kira today for bringing those remarks about the United Way campaign. Much appreciated and a super important initiative for all of us. Next up will be our operational update, and as always is our EVP Clinical Operations and Chief Operating Officer Sharon Pearson to let us know what's going on across our sites and services Sharon, over to you.
Great, thank you, Aaron, and good morning, everyone. In terms of our regular operational update, I'll walk you through the same numbers that I typically do. So our COVID numbers, you can see today we have 88 patients, less than 5 in ICU, and as of today, 3 outbreaks. If I compare this to this time last year, this is about 3 times more COVID than we had last year. And we do see that rise happen provincially right now in the province. There's twice the number of admitted patients with COVID than there was the same time last fall, unfortunately. In terms of staff isolation, as of today, there's 183 staff in self-isolation, and we've been averaging in around the 140 to 160 range lately. So we do see a bit of a peak in that number as well, reflecting what's happening within the province. On to the next slide, please. The pressures are reflected in our occupancy rate. So our overall midnight occupancy rate was well above 100, as you can see at 106. All of our acute sites extremely pressured and sitting well above 100%, many sitting above 110% to 112 this weekend. Our post-acute site, Satellite, and the St. Peter's site have been sitting well above 95% as well. So every single building that we have certainly is feeling the pressures across HHS. We have seen an increase in our ALC numbers. So we're sitting at 232 today. Maybe 6 to 7 months ago, we were much closer to around 130, 140. So we have seen that increase. On to the next slide, please. In terms of some of our surgical activity, we talk about this at the updates regularly. So while we aspire to be back to 100%, we're around 80 to 85% of our pre-pandemic surgical volumes as a result of the other pressures that we're facing and some of the health human resource pressures as well. Our ED volumes are either at or higher than our pre-COVID volumes. Certainly see that when you look at the discrete sites. McMaster has had inordinate volume pressures over the course of the last few months, and we've certainly seen peaks at the other acute sites as well. Would really highlight, though, the differential is the acuity that we're seeing in the patients arriving in ED compared to what we saw pre-COVID, and that really is another added stressor on the efficiencies, because obviously the patients require more of our time and services. Because of the occupancy pressures, we certainly had some periodic regional program deferral. We work with our partners across the province to prevent that, but certainly from an acute leukemia, from PICU, we have had to move patients out of our region as a result of our occupancy pressures. We are maximizing our physical space across all our sites to the degree to which we can. And I know that's an added pressure to the staff and units, but it is in response to the ongoing volumes that do arrive to our hospitals. And certainly I know at a local level, at a unit level, and then at a program and site, everyone's looking at efficiencies to ensure that we're moving patients as best we can through the system. We have a number of admit avoidance strategies in place and partnerships with community agencies to assist in having patients return home instead of being admitted. So we'll keep those patients or those programs going. And we're really enhancing our remote and our virtual care programs right now as well, which is facilitating and alleviating some of the pressures on our ED. We're going to hear a little bit about the Bill 7 implementation, which is underway at our sites as well. And really good news is that we were approved for an additional 30 beds at the Satellite Health Facility. 18 are already opened, and as of tomorrow, the remaining 12 will be open. So that will provide us 120 beds at the Satellite Health Facility. And I did want to mention the pressures of the hospital and the sequelae and the cascade of impact that has. And certainly there's been inordinate pressures you've all been reading about in the community with respect to the offload delays because of the challenges that we have processing the volumes of patients that we are seeing in the ED and really the bottlenecks we have with our physical capacity on the units. On to the next slide. Of course, we call out our health human resource challenges. There are inordinate efforts underway, recruitment efforts. It's a very competitive market, as we all know, for all disciplines. And certainly the challenges that exist in acute care also exist and are very pronounced in our post-acute partner agencies as well, which does impact our flow. I did call out our COVID numbers in terms of staff off and self-isolation. We have also seen a peak in our non-COVID absenteeism as well right now. And I know there's significant amount of flu going around that is certainly contributing to that too. And I just would want to emphasize again that there's a multitude of local and region, sub-region tables formed so that we can work across the system and find the efficiencies that will help all of our organizations. I spoke previously about the work we're doing to ensure we keep the EDs open in our region, and that's happening across the province. We have other work underway related to how we ensure repatriations and patients are returned back to their home community in an efficient manner. So lots of work being done to try to alleviate the pressures. So that's my update for today, and certainly happy to take questions later on, and I'll return it back to Aaron.
All right, thanks very much, Sharon, for that. And yeah, a reminder, the Q&A function is open. So if you have questions on what Sharon has raised or anything so far in our town hall today, you can always pose those questions using the Q&A function. Next up on our agenda is Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control, to give us an update on the COVID-19 pandemic epidemiology. Dominic, what do we need to know?
Yeah, thanks, Aaron. You can probably just follow up on Sharon's points here. So I'll quickly go through the epidemiology, the new subvariants that you hear a lot about in the media, just to give you a few ideas there. Quickly touch on COVID-19 vaccines, what's currently available, and then influenza vaccines. Next slide. So as Sharon already mentioned, we do see the expected uptick in cases, which again, we don't really know too much about, but we use hospital admissions with or due to COVID as a proxy. And that's what you see here on top. That's Ontario-wide. The hospital admissions at the bottom, you see ICU admissions. ICU admissions have came up quite significantly this week. Not sure whether that's a blip or an actual trend, but the trend is very obvious in the top figure when you look at hospital admissions. Next slide. These are the Hamilton specific graphs. You see again in the current week, we see an increase while it was stable prior. So it looks like we are lagging behind a little bit there. ICU is flat so far at relatively low levels. All of this being said, this is COVID, and as Sharon mentioned, there's many other viruses, in particular rhinoentro, around as well, which result in a lot of respiratory virus infections at this point of time, as we would have seen prior to the pandemic as well. Next slide. This is the current assessment by our public health unit. You see that they consider us stable overall with an increase in terms of wastewater signal as well as test positivity, which increased to 17.7% on October 14. Next slide. This is the latest model as shared publicly yesterday. And as you can see, the gray zone becomes less. That's because there's a little bit more certainty in the meantime how this may play out. The assumption here is no major shift in variants, and we'll get to that. It considers the rollout of the bivalent vaccines. In total, it estimates 591 hospital admissions of Hamiltonians between yesterday and February 28th. And roughly 45% of admissions in the 60 to 79-year-old population, which gives you the answer to the question, which patient population should be prioritized for any boosters, certainly 60 plus. As previously mentioned, in the last couple of months, it looks like what we expect to peak probably mid of December based on this model will be somewhere between what we've seen in January this year and the spring wave this year. Next slide. How do those fall waves look like in Europe, which typically is 1 or 2 months ahead of us? And I just picked a few countries here: Austria, Germany, France, Italy, and Switzerland. The latter still increasing. Austria looks like they are already behind peak. Is this the first peak of several peaks, or was that their fall wave? Is to be determined, but it looks like they had steeper peaks than what's currently modeled for us. But again, lots of uncertainty at this point, and we will just continue to watch at this point what's happening. Next slide. Now, the curveball, as usual, are the variants. So in this case, it's actually subvariants of existing variants, which may or may not be of concern. And I just added this table here from the WHO, which shows the variants or subvariants and sublineages that they are currently monitoring. And I wrote down a few here, BA5, which I will talk about, and then there's several offsprings of BA2 subvariants mostly that are being monitored. Next slide. What we are most concerned at this point in Ontario in terms of which subvariant or sublineage will be taking over, it's most likely going to be BQ11, which is a sublineage of BA5. This is an evidence brief from Public Health Ontario in case you're interested to read more about this. Next slide. Globally, we see different pictures, and probably at this point, we assume that only because one subvariant is successful in one area doesn't mean that it will spread globally to the same extent as we've seen this previously, because we have different constellations, I would say, of immunity, different vaccines being used, different levels of boosters, different level of natural immunity, and all of that combined may give one or the other subvariant more of an edge. In India, we see primarily BA275 at the very top, Singapore, also BA275, but what's taking over there is XBB, which is again a sublineage or a recombination with BA275. Europe, mostly BA5, us, mostly BA5, with still some BA4 at this point. But as I mentioned, there's some sublineages that are more likely to increase over the next weeks and months than others. Next slide. So what can you get in terms of vaccines? If you're 12 or older, you have access to one of the two now available bivalent mRNA booster vaccines. So either the Spikevax or the new Pfizer, which also targets BA5 specifically. Next slide. Influenza. As Sharon already mentioned, we do see some influenza activity already, and we certainly expect to see a more or less normal flu season this year, also based on the Australian experience where there was a significant flu season, similar to the years prior to the pandemic. So it's not that the concern that it will be even worse because we haven't seen a flu wave for 2 years. That hasn't really panned out, at least not in Australia, but they did see high activity similar to the years prior. Flu vaccinations are available through Employee Health Services starting this Monday, October 24th. For the general public, they will become available November 1st. And it's possible that we see a relatively early flu season, given the activity we already see. So getting the vaccines earlier than later certainly makes sense. They can be combined with the COVID vaccine, as you probably know by now, and you can visit the hub for the EHS locations and ours to get your flu shot. Next slide. So this is my summary slide for today. COVID-19 activity is slowly increasing. Hamilton seems to be lagging behind slightly behind the rest of the province. We are expecting an increase in activity for another 2 months until peak. Several subvariants that may or may not be taking over, but we do have with BQ11 at least a highly suspicious one that may become dominant by November or end of November. We have 2 bivalent COVID-19 vaccines now available for boosters, and as far as I know, both are readily available with no shortages. and the influenza vaccine becomes available coming Monday at HHS. Thank you very much, and handing over back to you, Aaron.
Okay, thank you very much, Dominic. As always, very informative and helpful. Okay, next up on our agenda is Leslie Gillies, our VP of Community Medicine and Population Health, as well as Interprofessional Practice Development and Clinical Education. She's going to talk to us a little bit about Bill 7. Leslie, over to you.
Okay, thanks very much, Aaron. Appreciate the opportunity to talk a bit more about the More Beds, Better Care Act and how it impacts our patients here at Hamilton Health Science. So to summarize, the most important, I guess, statement is to say that this act, or this Bill 7, allows Ontario's Home and Community Care Support Services, or HCCSS, to temporarily place patients who are awaiting a long-term care facility placement in an available long-term care bed within perimeter of a 70-kilometer distance while they wait for their preferred home. Now, you will preface it with the statement that, of course, that's not the intention. We're going to, the Home and Community Care Services, in collaboration with our teams, are working very hard to support people in making that decision for the short list or the short wait list within as close as possible to their geographical home. But this new bill does allow that if needed. From a context of HHS perspective, there's approximately 35% of our total 229 patients designated ALC who are awaiting long-term care placement within HHS. Next slide, please. So very important to know the roles of the Home and Community Care Support Services staff and team, and the roles of our teams and physicians as it relates to Bill 7. So the primary role of HCCSS folks is to determine the LC patient's eligibility for admission to the LTC for consenting but non-consenting patients as well. Again, as we said before, with Bill 7, it does give the ability to select a long-term care facility within 70 kilometers if required. But the most important takeaway, I guess, is that the patients, folks that are waiting for the LTC beds, do need to select a minimum of one LTC with a short wait list, which is a change. So they also have the ability to provide the long-term care facility with assessments information for non-consenting patients. And as well, they will be able to and continue to obtain required information to give that transfer of accountability or update to the LTC from the HHS health record for non-consenting patients to facilitate the long-term care placement process as described. They also can authorize admission to the LTC. Having said that, Bill 7, of course, does not permit physical transfer of the patient to the long-term care without the patient and our substitute decision makers' consent. And we'll talk a bit further about that, of what is the impact if people refuse once this has been selected. Next slide, please. So the role of our team, hospital staff and physicians, is obviously to discharge the patient. So if they're no longer requiring acute care, then they are discharged from the acute care services in the sense of their status. And so in consultation, of course, with our interdisciplinary team, there's ongoing dialogue with the patient, the substitute decision maker, that our level of care is no longer required, and they are now going to be deemed as alternate level of care. So once that's done and decided through our hospital staff and physicians, then the patient is referred to Home and Community Services and other partners as soon as the need is identified. The first choice, obviously, we're always really trying to support people to wait at home and to recover at home if deemed safe and with the appropriate services. But there are circumstances, of course, when that is not possible. So I think the other important takeaway is that this process of working through the decision as to choices and selecting short wait lists and facilities is really in the purview of the home and community service team. And I'll just go into that in a little bit more detail. Next slide, please. Okay, so, we're really emphasizing that once it's at that decision that they're ALC, those discussions, because the home and community service teams have that information available to them, they know that where the beds are idle within our community or within that 70K kilometer distance is. They have that information. It is their responsibility to have those conversations with the patients and or substitute decision makers and families, and then to hopefully come to a conclusion where they are able to select at least one short wait list facility on top of their other choices for long-term care. Ontario hospitals are required to charge a daily fee of $400 to all ALC patients who have been discharged and remain in hospital even though a supportive post-discharge plan is in place. This also includes, of course, ALC patients authorized for admission to a long-term care facility. So just to confirm, of course, we're working as closely and supportively as we all know with patients and families to determine the best destination for them if acute care is no longer required. But we are obligated that if refusal to accept a short wait list decision is made, we're not going to physically move people, of course, but there would be a per diem rate that we are legislated to apply to the patient. Hopefully that's not the case, and hopefully those circumstances can be avoided, but it is a $400 a day fee until the patient does move. So we're working through just sort of further refining our protocol and, being able to have those conversations if needed, only if needed, with our patients and families. And that would be our obligation if it is declined by the patient and a family. So it would be a management team working with the patient and family to explain the per diem rate and so on. But as we said, hopefully we won't get to that circumstance where we have to enact it. Next slide. I'm going to hand it back to Erin.
Thanks very much, Leslie. That's a very helpful update on that legislation and the processes and the impacts on us. Next up, we have our executive lead for our EPIC. Not Project Odyssey, just for EPIC now, Barry. We have Dr. Barry Lum here to give us an EPIC update, literally and figuratively.
Thanks, Aaron. Hey, everybody. Back again, and appreciate the opportunity to say a few words about EPIC again. So we're just about 20 weeks from go live, and we are moving through this evolution of what an EPIC install looks like and how we move into a permanent EPIC world. So we went through implementation, and that took us to June the 4th, and we moved to this phase now of stabilization, and then eventually, of course, we will be in a permanent state of optimization. But truth be told, this box between stabilization and optimization is blurry, and there will be items for stabilization that will continue for quite some time, if not even well into next year, but we also will hopefully arrive at a point where we feel we are stable enough that we can begin the process of optimization. So what does that mean for all of us? And what it really means is trying to identify those items that we must accomplish to be at a point of stabilization. Can you just go back the one slide just while I finish up on the thanks? Those items which must be accomplished to be at a point where we can say we are stable enough to begin some of the optimization work. So, you know, in an ideal world, stabilization would look like everybody knows what to do, everything is working, and there's permanent support team in place to continue all of the work. But the reality is that we're not going to get to that perfect nirvana at a fixed point in time. So what's the team doing? The team is focusing on major critical items over the next sort of 6 weeks or so to hopefully arrive at a point towards the end of November when we can say that we are stable enough that we can begin the process of optimization. But I want to emphasize that doesn't mean that everybody's ticket is going to be resolved. It doesn't mean that all of the items that people have identified will be dealt with. We will continue this work and we will continue to search carefully and be amenable to hearing about critical items from a clinical safety and quality point of view that need to be addressed and that might come up. And this happens and in an Epic install. And I would just ask you then to, as you think about the process for stabilization, to kind of think differently about tickets. When we first started, we wanted everybody to ticket their items as they came up, but we'd like you now to just take a pause before you send us a ticket. If you've sent one already, please avoid duplicates if you can. If this is something that you think is really important, but it might be an opportunity to have a conversation with a colleague before you fire the ticket, just to see if they've found a way around this or that they're already aware of a fix. And please think about what's the difference between nice to have versus clinically important and things that we really need to address. We absolutely don't want you to think we're not listening. We just want you to understand that the team is now down to a more sustainable number of members, and their capacity is not what it might have been when we went go live. So let's go on to the next slide, please. So where are we today? For many of you will be aware that the post-live visit number 2 is underway. Those site visits have been occurring this week and are a tremendous opportunity for staff and physicians to provide their feedback to the team. And I know that there's been lots of feedback provided at many of those sessions. The importance of these post-live visits can't be overemphasized. It really is a critical opportunity for us to get feedback and understand where we're at. If you haven't taken the opportunity yet to respond to the survey, as you're also thinking about getting finished on your My Voice Matters survey, please take a minute to deal with the survey related to the post-live visit. We're also in the process, and Carissa is working really hard on this, of standing up opportunities for staff and physicians to enhance their level of comfort in the system by doing some further training. It's a really great opportunity when you're sort of getting good, but not quite where you'd like to be, to take a pause and look at some other training options and tune-ups that might help you to feel even better in the system. So I'd really encourage you to take that opportunity when and if you feel like you're ready. New armbands will be delivered to all sites, both adult and pediatric, and you'll hear more about that over the next month or so. And I'm sure you know, but we would really encourage you to help us, that MyChart is a tremendous opportunity for us to engage our patients in their care. And we would encourage you to take every opportunity to encourage patients and family members of patients to sign up for MyChart. We're at about 30,000 now. We'd like to be much higher. So please, whenever you can, encourage your patients and families to get into MyChart. Next slide, please. I've really talked about the post-live visits for the most part. The survey has been extended to October 27th, and please take an opportunity to do that for us. There will be another round of visits in February, and we'll look forward to that, and you'll hear more about it when the time comes. Next slide, please. couple of comments about registration. We have had circumstances where registration patients have been incorrectly registered, or they've gotten the wrong OHIP number and so on. So please, whenever a patient is being registered, it's absolutely important that an RTE query occurs. Please, if you can, verify the primary care provider on every visit. I know that sometimes patients are vague about this, or they may not actually even know the name of their PCP, but whenever possible, we would really ask you to do that. It's critical in terms of communication of all of the clinical activity in the hospital to find its way to the PCP so that they can continue to provide the care they want to. Please avoid ever overriding the demographic information like the date of birth and the healthcare number. And of course, this applies to all aspects of a patient's journey in the system. Next slide, please. So just a few reminders. There are, of course, boards up in all the care sites that identify patients, and you'll see circumstances where you may see 3 asterisks as opposed to a name. This is your cue to know that these patients are considered confidential, and in other circumstances, in another list, they'll be identified as red in the census. Please remember, secure chat is for non-urgent patient flow communication. It is not a way to deal with urgent clinical issues, and please avoid then firing a message to a colleague that requires action on an immediate basis. Again, I would emphasize the My Chart whenever possible, and then a few other items here specifically related to the new issue about initiating an ALC, the importance of keeping thin charts on the units for the very few number of circumstances where we must have papers. There is an opportunity for a quick release workflow for health records should you be in a circumstance where somebody needs access to that, and we can provide you with that information. And of course, the importance of documenting any adverse events. And most importantly, from my point of view, is that we exploit the opportunity of Epic to use barcode med administration and at the bedside scanning whenever possible, together with the use of appropriate labels. And that would be it for me, Aaron.
Thanks, Barry. That was a truly epic update. Really appreciated. I guess up next, I'd like to introduce myself. I'll be talking a little bit about the employee electronic monitoring policy. So we did submit something to the workforce in a communique. As you may be aware, the Employment Standards Act was updated, asking employers to please provide for their workforce a policy posted this month around how the organization might engage in electronic monitoring. So these are the ways in which your activity using work collaterals could or might be tracked. Now, this isn't to say HHS is watching everything everyone does, but rather to outline where those opportunities might arise and what we as an organization are saying we will and won't do. So it outlines all of those circumstances. And of course, you can review that. That communique was distributed and I believe also exists on the hub for your perusal. And it can also be considered in light of other policies that relate. Of course, one would expect that sort of monitoring policy would have to exist in conjunction with other policies that we have around employee conduct and use of hospital resources. So that's the case. I think that's probably should be the sole slide on that. Okay. Next up, I'll introduce Susan Pucciarelli, who's our Director of Health, Safety and Wellness. Susan's going to give us an update on some new wellness initiatives occurring at Hamilton Health Sciences. So Susan, over to you.
Thank you, Aaron. And thanks everybody for participating today. I'm very happy to present to you an opportunity that has come our way from Wayfound Health. And this is part of the strategy that we have looking forward to increasing our wellness opportunities, services and resources, et cetera, to all of our people at HHS. So just to reiterate, we are committed to developing a sustainable culture of wellness and safety so that all of our employees and physicians can achieve their optimal well-being and deliver the best care for our patients and families. We absolutely recognize that there are significant contributing work factors that have been affecting the well-being of our people. These include some of the things that we've already heard about today, vis-a-vis our staffing shortages, our patient volumes, the ongoing COVID environment. And we recognize that these are all contributing factors to people having that sense of balance and that sense of well-being. We do have a multidisciplinary group, so an advisory council for well-being for our staff and physicians that consists of representatives from different disciplines and across the different sites. And our focus is really on pandemic recovery and our future to create a sustainable framework to support our psychological health and safety and well-being, using best practices and evidence-based information. And currently, you're probably already aware of a variety of services and programs and resources that we do have available, including our Shine Wellness programs, our Peace team that provides on-the-ground support to our staff and our patients, our EAP services, which was already mentioned earlier as well, in addition to external resources. And all of this information can be found on the hub on the Shine Wellness page under Health, Safety, and Wellness. So please, if you're not familiar with the different services and resources that are available to you, please go in and explore that information that's available so that you can potentially find something that would be the right fit for you. So although we do have these existing resources, we are continually looking for additional resources to be able to supplement what we have in place. And this leads us to the opportunity that we have with Wayfound Health. We recognize that this is not a one solution fits all, so we continue to look for different opportunities and, as I said, services and programs. So with Wayfound, they are offering to us as HHS staff and physicians free of charge their program called Before Operational Stress. Wayfound has received a government grant, and in partnership with the Canadian Institute for Public Safety Research and Treatment, they're offering BOSS to healthcare workers across Canada. So we're quite fortunate that they did reach out to us and are looking for us to participate in this program. And while it is a research study and they've received funding for research, you don't have to consent to the research portion of this to take advantage of the BOSS program. So I just want to make that clear. You can still participate in the Before Operational Stress program modalities that are being offered. And by doing so, it doesn't mean that you have to participate in the research. That decision will be entirely up to you. Next slide, please. So Dr. Megan McElleran, who has worked in the field of frontline mental health for over 20 years, has been asked to develop or was asked to develop a program that recognizes the need to address root causes of the environmental stressors and through proactive measures, providing program modalities that will help people to achieve, again, their optimal well-being. And when we talk about resiliency, I just want to be clear in the case of the BOSS programs, it defines resiliency as awareness and a healthy, authentic relationship to help people achieve function at optimal levels in all facets, not only of their career, but in their lives as well. Next slide. There's a choice of 3 different programs to support healthcare workers that are working in high stress environments to learn and practice ways to protect your psychological well-being. So the 3 modalities are listed here. So there's the BOSS Online. This is an 8-week program at your own pace. It's an online learning platform, and this will be accessible to you at all times so that you can work through this at your own speed and at your leisure. There's also BOSS Peer, and this is a facilitated group session. So it'll be a cohort of 20 participants, and this is facilitated by a Wayfound Health BOSS professional, and it will be an online meeting format. And then the third opportunity that has been presented is the BOSS Intensive. And this one is clinically led. It's small groups of 8, and this is a group therapy model. Next slide. The participants who do go through either or any of those particular modalities, we're looking for specific outcomes to improve symptoms of mental health, emotion regulation, personal resilience, and social support, and also to reduce the stigma around mental health. And this is one of the things that we do find and is researched quite broadly, that it's the stigma around mental health issues that tends to prevent people from seeking assistance or seeking support. So again, part of the aim of this program is to reduce that stigma and to open up those opportunities for people to seek further support. Next slide. There's more information that will be coming to you soon. It'll be available on the hub. We're going to also promote on our social media channels and through our email distribution in our dispatch. We are looking to launch this close to the beginning of November, and we hope that you'll take the time to review the information and participate in the BOSS program, whichever of those modalities, if you feel that it will be the right fit for you. So we're pleased to be able to bring this offering to our staff and physicians here, and we look forward to any feedback you may have. Thank you very much.
Great, thanks very, very much for that, Susan. We've got a pretty packed agenda today. I think we're getting near the end. So we are at the end. So again, we've had, and also some really good questions today, I have to say. So thank you to everybody that did type in a question. Again, the answers have accrued in the answered tab. If there's anything that you thought about after the fact or you didn't get to ask today, you can always email your questions to hhsnews@hhsc.ca, and we'll make sure that an answer gets back to you as quickly as possible. I think we're going to move now into our celebrations, which is always a cherished part of the agenda for this meeting. I know, Dr. Stacey, you had mentioned to me that you have a celebration to give. So what would you like to celebrate today?
Yeah, thanks, Aaron. Yeah, I'd like to celebrate and congratulate Tim Dietrich in taking on the interim role of VP of Quality and Performance. I think you'll all know Tim quite well, and we really appreciate Tim stepping up and taking on this role while we go through the process of getting a formal recruitment. But there's lots of work to be done, particularly with accreditation, and Tim will be very helpful to us in that process.
Great, thank you for that, Michael. Kelly Campbell, you've come on camera. What would you like to celebrate today?
Yeah, thanks, Aaron. It is National Healthcare Facilities and Engineering Week. So I just want to acknowledge all of our facilities management teams and our capital teams and their leadership under Bob Hoffman, George Pankey, and Alan Buxton. The great work they do keeps us all of our facilities running every day. So very appreciative.
Amazing. We have no shortage of facilities to maintain either, do we? Thanks for that. Just a reminder to our viewing audience, maybe I'm a bit rusty. I didn't mention that you can type your celebrations into the chat function and I'll read them out. So I know our panelists here have had some wonderful celebrations. I see here from Rebecca Fleck, happy Occupational Therapy Month. So thanks for calling that out, Rebecca. And from Mike Campen, happy National RT Week next week. Thank you very much, Mike, for pointing that out. And I also see from Daniela Traiani, happy Spiritual Care Awareness Week to all the psychospiritual practitioners at HHS. And while we're on the topic of celebration, Dr. Dominic Murr says, happy Infection Control Week. That's awesome. Okay, I have two Leslies in the queue. I'm going to go Leslie Gillies first. What would you like to celebrate today?
Oh, thanks, Aaron. I just want to, I think Kelly has beat me to the punch here. So thank you to her and obviously the team and management team and physicians at West Lincoln. Incredible work and tremendous effort to resume obstetrical services and full surgical activity at West Lincoln. Second, thank you to the Satellite Health facility team, Kelly O'Halloran, and physicians and clinical team and management, opening up those final beds to have under tremendous challenges with recruitment, but great support and interest. Thankfully, we've got new members joining the Satellite Health team. So those beds are opened as Sharon has outlined, but that's going to be tremendous support to our patient flow and support of care. Thank you.
Awesome. Thanks very much. Leslie Gauthier, what would you like to celebrate today?
Yes, so I have two teams to celebrate. One is, I think I was remiss and didn't celebrate our MDRD teams a couple of weeks ago. And Just want to acknowledge the contributions they make often behind the scenes to make sure we maintain all of our standards around sterility and reprocessing. So congratulations to that team. And the team that celebrated this week is our pharmacy technicians. And just to remind everyone, as we went live with Epic, a phenomenal amount of work happened with pharmacy automation, pill pickers, box pickers, AccuDoses, OmniCells. These are all technologies that are safely restocked and maintained by our pharmacy technicians. So really want to give them a big call out for really contributing to medication safety across HHS.
Fabulous. Thank you very much. I see one here from Dawn M as well, thanking the communications team for their help promoting Cybersecurity Awareness Month, and also to all staff across HHS for your continued vigilance and reporting of phishing attempts. You know, you can always send those to thisispam@hhsc.ca. And if you're like me, you get lots and lots and lots of that in your inbox, and you have to weed it out. Maybe I could close just with a celebration of my own. I want to thank everyone across HHS that's taken the time to fill out the My Voice Matters survey. You know, we have almost had close to 5,000 respondents, but we're a really big organization, so there's lots of room for additional people to still fill it out. The value of doing that can't be understated. Well, it could be. It can't be overstated. You know, I can tell you, being a part of some of the projects in our strategic plan, whether it's on wellness, workforce planning, the Equity, Diversity, and Inclusion project, each one of these projects always mentions the My Voice Matters survey as being an important input that we're going to use to help, one of the inputs we're going to use to help guide the work and understand what's valued by the workforce. So the input that goes into it is not just about dreaming up what we should do, it's about guiding the things we've committed to do already. So if you can take the 10-15 minutes to fill that survey out before it closes at the end of next Monday, it'd be really, really important, I think, valued to helping steer the things that the organization's looking to accomplish. We've got a pretty good response rate so far from the workforce, lots of room to improve, and I'd sure love to see more of our physician and resident colleagues filling out the survey so we can say with confidence that their voice was captured. So please give it a moment and try and fill that out if you can. And maybe Michael will close there and I can offer final remarks to you and take us home.
Great, thanks, Aaron, and thanks everyone for joining the town hall today. It was certainly my pleasure to step in for Rob McIsaac and to lead us through this, and really want to thank all of the presenters for their excellent updates that they've provided to us today. So thanks everyone, thanks for joining, and please do encourage all of your colleagues and especially those physicians and residents to complete that My Voice Matters survey. We really need to get as much response as we possibly can. Our next town hall is scheduled for November the 7th. So thanks everybody, take care and enjoy the rest of your day.